To see everybody here, and we wondered if when you saw the title of today's topic, it would confuse people or scare people because it's a really long word. There are apparently two correct pronunciations, maybe more, I don't know, but it's either anosognosia or anosognosia. Either one is correct. So glad that didn't scare you off.
And I say anosognosia because I'm from New Jersey, and I guess that's what we say up there. So, but however we say it, tomato, tomato, it's a word, and we're going to teach you about it today, and hopefully give you some interesting pieces of information that will also be helpful. So this is a term that was coined by a neurologist named Joseph Babinski. We're going to show you a little picture of Dr. Babinski. And so he was in the 1800s, early 1900s, and he coined the concept of anosognosia. And what it is, it's a condition in which a person has a disability where they cognitively are unaware of their underlying physical condition. Okay. It was first noticed when someone would have a stroke and one part of their body, one half of their body was paralyzed or weak, and the patient would not know that had occurred. They had no insight into it. And so they realized that there was a disconnect between the part of the brain that could interpret what the body was feeling and then give the person insight into it. And so with stroke, it was first noticed, but then it was also noted that people with certain psychiatric illnesses, including schizophrenia and bipolar, often had similar lack of awareness into their disease process, not thinking anything was off. And we see it in dementia, and it's very common in when we see things. So sometimes we see it very early on as one of the first early symptoms. And then oftentimes, though, about 90% of people by the advanced stages will have this characteristic. But sometimes it's much earlier on, and that can pose some challenges that we're going to talk about. And Dr. Babinski also, by the way, if you've ever heard of the Babinski reflex, we scrape the bottom of a foot and see if a toe goes up, and that indicates some brain dysfunction. Well, he also figured that one out, and then he developed Parkinson's later in his life. So he was well aware of all the neurologic conditions that we can have. Okay, so you can go ahead to the next slide. So I just wanted to describe where this is, because oftentimes when a loved one is experiencing a symptom, it can appear to be one thing. It can appear even to be intentional. For example, someone maybe not wanting to admit that something is wrong. That is a different condition. There are some similarities and overlap with denial, and we'll talk about that. But there's actual brain dysfunction, and the place where anosognosia is said to occur is in the parietal and frontal parietal areas. So the parietal lobe is the yellow lobe on the screen, and the frontal lobe is the blue lobe. And that black line where they meet is the frontoparietal area and all around that area. And it's been shown that people with a stroke or a lesion or damage in that area have this symptom. And so in patients with dementia, there's often disease everywhere or a lot of places in the brain, certain lobes more affected than others. But if someone's experiencing it, there's likely some disease going on in either one or both of those areas. Okay. Okay.
Can it be questions now or later?
Go ahead, you can answer.
Can it be precipitated by an injury as opposed to
yes,
Age
or mental illness?
Yes, I mean traumatic brain injury. There are, just like if someone had a stroke to that part of the brain, they can experience something like this. Yes. And anosognosia, if you break it down, the A means in Greek without. And the nosos is disease. So nosos, right? So without disease. And then gnosis means knowledge. So it's without knowledge of the disease is actually what that long involved word means. And the reason that we wanted to talk about it is that over the years that we've been working with families, this condition actually adds another layer of complexity and challenge for the patient and the family. If somebody is aware of their condition, there are a host of emotions that come along with that, and accepting it is difficult, and all the things needing some more help, that's very difficult. But if they're completely unaware, underlying the disease is an absolute unawareness, that brings up a whole nother level of feeling defensive if somebody brought something to me. So I would feel the same way. And we kind of talk about that in person, that if you came to me today and said, Robyn, sit down, we've got some things, and I did not believe it, and I knew that I was just like I am right now, I would argue and I would fight back and I would defend myself and I would try to convince you. And so that's where this can breed a lot of stress and strain between the loved one and the caregiver, who are trying to do their best to keep everyone safe and sound, bring to doctors, start medicines. And so we see stress rise. And so oftentimes, if we can identify that this is going on and we can educate, we can understand, we can help, and we'll talk about approaches later, but we can actually come towards it and make the situation a little better.
Is there a middle ground somewhere? I'm sure there is, as a matter of fact, a middle ground somewhere where it's almost like apathetic, not aware, but not defensive, doesn't care. I mean, care, that's not the right word.
Yeah.
Doesn't just isn't part of the picture.
Yes. Yes. Apathy itself is an actual. Yeah. It's a great point though, but apathy is a very significant and common finding in our patients.
Yeah,
and so
you kind of talked about defensive and the other, but
exactly.
My situation is different. Put it that way.
Yes. Yes. And apathy is different in itself. So no, it's a good point. But one of the most important things to remember when we're dealing with this is that it's not a conscious intent. And it's not an intentional coping mechanism and an argument, it is actual part of the disease. So I try to think of it little like, we have wires in the brain. They're all working all night, all day. But if that particular wire that gives us that insight is cut, that's not a willful thing. That is part of an illness. And so envisioning that when we're trying to care for somebody helps us understand their reactions, and it helps us change our approach. So, okay. The other thing is that if somebody's experiencing this, there's evidence in studies that show there's a greater degree of neuropsychiatric symptoms, meaning things like agitation, anxiety, difficulty sleeping, later on, potentially delusions or hallucinations. There's an increased incidence in people who have this symptom early on in the disease. And there's also a quicker conversion, a change from mild cognitive impairment to dementia in patients who actually present with this. So we do see a bit of a faster progression. And we don't understand all the ins and outs of why that is, but it's an interesting finding to know. And that again, raises all the stress at home. So it gives us some challenges, as I said, for the patient and the caregiver. And some of the unique challenges are, we're here at the medical offices, right? And we're not in a silo. People are seeing multiple providers, different specialties, and everybody's saying, okay, here's the plan. Here, take the medicine and go get the MRI and start the physical therapy and keep up with those exercises on the other days and all of this. And the care partner or caregiver is trying to help somebody keep up with the routine and feels very, guilty for not being able to kind of rise to the occasion that we're all expecting. This puts a real block on their ability to do that. So we have to address that and not just keep piling on instructions and advice and directions. So we really want to acknowledge this and then be able to tailor our plan to that. The other thing is people can feel very judged by people who are not within the intimate situation, right? Oftentimes we have friends that are outside it, that everything appears fine, or family that could be out of state that feels like, well, wouldn't it be easy just to get them to do the exercises? That would help. So it's it's a condition that most people don't even aren't aware of. So hopefully this will give you some words and some resources to help educate others, because the last thing you need to feel is judged for working so hard. And then also, giving the information to their other healthcare providers that we're dealing with. So it can just bring the whole team a little bit closer together. So now we're going to kind of move into some of the approach. Oh, yes.
Is that a word that's pretty common with other medical providers? Like if I were to tell my mom's other doctors, well, she has dementia, but she also doesn't know she has dementia. She has anosognosia. I don't know if that's right.
That's good.
Would they know that, or would I need to explain a little bit more?
It's a great question. There's a lot of things that we learn in our medical education that are kind of like smaller chapters in the back of the book. that we don't use every day. And so I imagine it's in most people, it's been heard, and, we understand kind of the Greek and Latin words of it, but to know how prominent it is and to be able to identify it, because oftentimes people go to their primary doctors by themselves. They come here with a loved one because we kind of make that a priority, but oftentimes they present really, really well at other physicians. So it's a hard thing to bring to the surface. And without that, input from you, just very, very helpful. So I think it's definitely worthwhile to bring to anyone's attention. We had someone go to an emergency room not long ago, and they were able to, convey to the emergency room physicians that, this person is unaware of their diagnosis. So when they say everything was just fine and give you a report about not falling, and it was different. Once they got that piece of information, I could tell it really helped the team make an accurate plan.
Does it apply, if you have this with not acknowledging or not understanding that we have dementia, but you also perhaps have another condition, heart condition, whatever, and are you also unaware of other things?
It's usually based around the neurologic condition. People are pretty darn accepting of their memory. They may forget they have those things,
Right.
but usually it's not as adamant of a denial of other conditions that I see.
Right, and even within our realm, they can be very accepting of the fact that, I lose my keys every day, like they admit that. But they're going to say, but I'm still capable of making a gourmet meal for 12 people, and I'm having a party, and they can't do that anymore. So it can be very inconsistent into what they'll recognize and what they don't.
Are we going, I don't want to jump ahead or anything, are we going to get into, since the person doesn't accept or know or whatever the condition, it's very hard dealing with people outside, forget about doctors and whatever, I'm talking about friends, neighbors, and so forth. If you got to get in, wait. But if not, what I find is, how do you talk to a friend when the person says they're fine, except for their back?
Yeah.
Yeah,
Well, that was a perfect
Because
event.
it's very hard, getting support, because you can't help it, or you can, but I mean.
But it's exactly what people are saying to you. Well, it seems like everything's fine. What are you talking about, right? No one understands.
Or even if they think things aren't quite fine, but when they ask the person, they say, oh yeah, except for my back or my whatever,
Right. Whatever they're willing to. Yeah.
Well, we're going to get into right now. That's
But if you
perfect.
gotta get in with it, fine.
We're there.
Yeah. So that makes it even so much more frustrating, and in lots of
And
ways.
lonely. I mean, you
And lonely.
can't tell your friends.
Actually,
I mean, I feel like I
Exactly.
can't tell my friends when the patient doesn't.
yeah, it does put, yeah, I mean, I think it depends on your, where you feel comfortable, who you feel comfortable sharing it with. But I think,
But can I interject?
Yes.
I think that one of the issues is going behind the back of the patient, or whatever the right term is. I, in a couple of cases, have gone to friends and said, and told them, I said, you've done such and such, and here's what's going on, that's why you're not getting phone call, whatever it might be.
Yeah.
But in general,
Yeah.
it's kind of hard to go around and say to people who normally would be affirming and so forth and so on, if the patient says, oh, I'm fine, except for my back.
Yeah. Well, we're gonna go through kind of the approach right now that we're gonna take with our loved one, and then we can come back to how to approach friends in a little bit. But I think that kind of getting figuring out how to lessen the stress within the home and with the medical plan would be kind of our first approach, and then we can open it up to
That's fine.
other topics.
No, that's fine.
Good. Thank you for bringing that.
no, that is really, really, it's a hard spot to be in. So what do we do? First of all, as Robyn said, there's a lot of responsibility and a lot of direction and everything put on the caregiver. And we're all about that here. We say, take charge, and we tell you what you need to do. And then if you go home and you try to do this and you met with this resistance and maybe a little bit of anger, it's really a tough place to be. So how do we deal with this? Well, the first thing you have to do is be kind and patient with yourself. take a deep breath, realize this is the situation you're in. Nothing easy about it. Okay. So speak to your loved one's physician if it's here and say, I know it's important that I do this and this and this. This is what he or she is accepting at this time. And we're working. It's just going to take a little bit more time. Sometimes you can't do everything at once. So try to bring some calm and patience to the situation, because any kind of frustration, impatience, anger, anything that you have, kind of take some deep breaths and try to leave that a little bit just for the time being if you're getting ready to have a conversation with them or you're trying to persuade them to take a medication or do something that they don't believe they need. And also realize that oftentimes our patients and their caregivers have had an ongoing relationship for lifelong almost, and you've had patterns. And maybe, for example, mom was always somebody that you could discuss anything with, and you could have this give and take and go back and forth. And now all of a sudden that's changed. And that is sad. And we have to kind of come to grips with that and kind of grieve that things have changed. And it isn't what it used to be, and you can't expect that sometimes. Also knowing, as Robyn said, they didn't cause this, they didn't choose it. So what are we left with? We have to be the ones to build a bridge and go to them. We have to be able to interact in a way that brings them more peace and actually improves the relationship, because really that's what the most important thing is. And we have to meet them where they are. And we have to really consider things from their point of view. And again, as Robyn said, if someone was telling you something you knew wasn't true, you would protest loudly, I'm sure. Or it's like trying to get them to see the grass is green and not blue. They see it as blue. And there's no amount of correcting, there's no amount of repeating in a different way that you're going to get them to accept that. And it's exhausting when you try. So we have to stop pushing our agenda. You cannot convince them. More than likely you can't. So what do? There is a method, and I see you have the book already, that Dr. Xavier Amador wrote about this anosognosia. And it's called I'm Not Sick, I Don't Need Help. And he talks about a communication technique that's called LEAP, L-E-A-P, and it stands for listen, empathize, agree, and partner. So we're going to kind of focus on the very first part of that, is the listening. You have to listen without judgment and really hear their words and what emotions tied to it. And we kind of have to stop thinking, okay, what you're saying isn't true. And, I'm going to try to set you straight. I'm going to try to, I'm going to argue, basically. And we have to stop. We can't. But you listen with respect and you listen without judgment. And hopefully you can then reflect back what you've heard to them. Doesn't mean you're agreeing with them. It letting them know they're heard. And that does wonders. It really brings down that level of that agitation, that argumentative stance. So when you don't use the word, like say you're reflecting back what you heard, but then you want to add something to that. You want to say, oh yes, I heard you don't really like taking those medicines, but your doctor says you really need them. So anytime you put a but in there, you're negating what they just said, okay? So you can reflect back what they said and then stop. Our inclination is to keep going. I hear what you said, but it's not right. Listen to what's true and important for them. And then you can reflect back and you can say their words back to them and say, did I get that right? Is that what I heard you say? No, and then they're heard, and then you have a chance of moving forward. So you have to connect with their emotions, and you might not get instant compliance, but hopefully you've brought the level of anger down and the level of trust up, and that's what we're really trying to work on here. And then empathize. And this is just saying, yeah, I can understand how you feel that way. I understand that. If I was in your shoes, I might feel the same way. Okay, think about what that does. So you're really putting yourself in their shoes. And when somebody hears this, it typically makes them feel that you're a little bit more flexible and understanding, and then it kind of generates a little bit more flexibility in them as well. And then the last part of that is the agree. And sometimes you agree, and you can find what you're listening for when they're talking is some kind of common ground. If they say, I don't need those medicines anymore because I'm feeling so much better. Oh, you're feeling better because you don't need the medicines because you're feeling better. Is that what I hear you say? And then you might say, eventually, you know, we're going to go through some other methods here, but eventually you can give your opinion, and I'm going to get to how you can do that. But you can say, you know, I'm thinking of a time when you stopped taking your medicines and you didn't feel good. And then let them respond back. Do you see how we're doing that? And then they might eventually come around to the fact that we both agree it's better for you when you feel good. And then gently, you know, maybe they can kind of see, oh yeah. So you don't want to tie it to, if they don't believe they have memory loss, you don't want to say you need this medication because doctor says you have memory loss and this is good, you know, if they're not accepting it. So you can say, you know, these are the medicines your doctor prescribed. You see you feel better on them. It can be for anything else, but if you start tying it to the diagnosis that they don't accept is usually when they have more difficulty with that. Is that, I know it maybe doesn't seem like it's exactly truthful.
Sounds like lying.
It sounds like lying. So a lot of times we say this medicine is to keep you as good as you can be, you know, that kind of thing. If this is a little helps your brain. It helps you know, we have medicines for all parts of our body. These medicines that your doctors have prescribed help you stay as good as you can be. So I don't know. Yeah, I know this is hard.
I've found the expression, help me understand how this makes you feel.
That's good. Mm-hmm.
And
because you're really paying attention. You're really listening.
Because if he keeps repeating what they say, I feel like after a while they think, well, it's just
right.
repeating what I'm saying.
Right.
So
I like that.
Say it one more time.
Help me understand how you feel when you take or don't take this medicine.
So,
well, as opposed, in addition to saying, what I hear you saying is.
Yes. Did I get that right?
Yeah.
Yes.
Mm-hmm.
Exactly.
It's just kind of a different way to say the same thing that kind of keeps the conversation going.
Mm-hmm. So there's also 3 other tools that he recommends when you're trying to find some common ground. And that is apologize, acknowledge, and agree. So eventually they might say, well, what do you think? And and a lot of times he advises to delay. I will tell you what I think, but really might not be as important as what you think. I want to hear a little bit more about what you're thinking. And I'll tell you later. Is that okay? So that, you know, it's like you have to talk a little bit more. They're maybe not quite ready to hear what you think. You don't want to offer your opinion too early. And remember, no matter who we are, if someone's giving us unsolicited advice, we don't want it, usually. It's not welcomed. If the person does ask your opinion, yeah, you can delay. And sometimes they might not ask your opinion, and then you think, now, what do I do now? So you can ask, you can say, can I tell you what I think? And then you say, before you say it, you say something to the effect of, here's the apologize and the acknowledge. Before I tell you what I think, I must apologize because what I think might be hurtful or disappointing. And I could be wrong. So when that's the apology and the acknowledgement. And sometimes you won't agree, but you can always agree to disagree. You say, okay, and we just agree to disagree on this. I understand how you feel, and you understand how I feel. So this lack of insight, like I said, can be inconsistent. It might be even different from day to day a little bit. So, but I really would pay attention to what they're sensitive to, what they really won't accept. I did work with my mother-in-law. She needed someone to come and do medicine reminders for her. And she was very resistant to that. But she somehow got it in her mind that this was housekeeping. You know, I knocked on the door, they got her medicine out, told her it's time to take her medicine. She thought it was housekeeping. So that was fine. I'm not gonna correct it. She accepted that. So meeting them where they are really is trying to find a place that you're getting, you know, she's getting her medicine, but she's taking it and not resisting. And you have to be a little bit creative. You have to be patient. And there are some situations, right, Robyn, where if it is a safety, like an immediate safety issue, where I don't think we can do this. I think you can still use these techniques and say, I hear what you're saying. I understand why you don't like this. However, right?
Yeah, I mean, there's some, you know, there's always exceptions to the rule. And so these are for kind of the general interactions that we would have day to day, and accepting things like medicines. But, you know, if somebody, you know, demands to drive and we know they're completely unsafe and danger on the road, we're not sitting back and empathizing. We're actually removing the keys, and we'll deal with the reactions later. And we, you know, there's very difficult situations that we do have where sometimes it's out of these bounds, but this is more for kind of the general. So yeah.
This is more for preserving the relationship. So it's just not, you know, this friction and this frustration.
Yeah. And it's, I mean, it feels good even to hear you say, we were saying these things to each other and we were you know, kind of role playing a situation. And it's amazing how you don't really have a comeback when someone says that must be really hard to feel that way.
No, everybody wants to be heard.
Everybody. And it just kind of, you don't even have anything to retort to it. So even just practicing it a little bit, I mean, it sounds corny, but when we did it, you can start to understand how it might feel to someone else. And we do say the connection is the best treatment for the entire situation. You know, there may be a medicine that we've recommended that isn't, you know, essential, right? We thought it might help, but is it causing a huge amount of friction? So even going back to all the, you know, if someone's on 20 different medications and refusing to take medications, we kind of need to relook at that as a medical team too, and see if we could simplify things and what are the most essentials and how can we get those on board? How can we reduce the arguing and the disconnect and those things? That's not making anyone feel good. And so it's definitely something to kind of discuss with the healthcare team, because oftentimes we can kind of help prioritize the few things that we really need to focus on and take some of the extras out for the time being. But we see people a lot who take, you know, after coming here a few visits, the first visit might be very, very, very difficult for someone to arrive here and confront, but then building trust, building rapport, not feeling threatened, feeling very connected to us, it tends to kind of, over time, most people, gain a level of feeling good when they come. And then we can kind of break some barriers and help. So it does take time, but oftentimes we can get there. So now,
I want to go back to his question.
Yeah.
About his friend.
Yeah.
That's always such a personal thing about what some people are very open. Some people, you feel like you're betraying her trust. Is that what I'm hearing you say?
Yeah, well, yes, I think so, like, Streets doesn't admit it. But doesn't admit it, it doesn't, it's just like it's not there. Idea is that everybody has a different situation, but it's like when I have, it's their friends, neighbors, whatever, who wonder what's going on. But
Well, I mean, everyone's, we can't give
if they have cancer, let's just go, if they have cancer, you
Right.
say, Joyce got
That's
cancer.
right.
Oh, everybody, well, that's a lot different.
Yeah. Well, it used to be though. I mean, 40 years ago, cancer was like this. Everyone whispered it, right? We've come a long way.
Yeah.
So we're here to dispel stigma, but also respect people's dignity and wishes. But, one really important thing is depending on where someone is in the course of their condition, the caregiver, if the goal, like we kind of go back to what are the goals? What are the goals? Most people say the goals are to, remain at home together, to, minimize strain in the home, to have great quality of life, to have these great friendships. But oftentimes when we hide things or keep them too close, the caregiver strain gets so high that the health of the caregiver is in jeopardy because they haven't had the support. And oftentimes that leads to some separation, even for temporary, because someone has a health issue that was stress related. So if somebody can understand that those are the consequences of not getting support, then we kind of have to regroup a little and kind of weigh the risks, benefits, just like we would with any medication about talking versus not. Trusted circles are different than strangers on the street. There's lots of
Circle back just
ways
a
we
minute.
can.
Why would you hammer home to the patient if they're perfectly happy with the situation?
You wouldn't.
I mean.
That's right. You're right.
No, you're right.
You're right.
And be
Okay,
happy
they're
with that.
perfectly, more or less content with the situation.
Yeah, that's
I
right.
mean, why should I say, well, you have,
That's right. That's exactly right.
No.
But that's exactly right, is that there's several ways to handle it. But some people find that, their loved one isn't aware. If they have anosognosia, they won't be aware. But bringing friends closer, if people pull away, they kind of follow your lead. And so the more private we keep things, it kind of gives people a little bit of a don't ask, don't tell. We're keeping this. People tend to pick up on minor things, but kind of want to maintain your dignity and privacy and oftentimes shy away when the best treatment for people with cognitive impairment is social engagement, connection to friends, people helping you pull them out into activities, take them out for lunch, giving you a break. So it kind of backfires in a lot of situations. And so it's not easy, but it can really breed a very close village of support for you and for your loved one. So it doesn't mean that your loved one has to be faced with it every day, but there may be a couple of people that become really important to both of you that could help. So if it's not an easy answer, but we just see it. Yeah.
I already have, so I'm sorry.
No. Any other questions? That we're happy to open it up to anything.
There's a question in the chat. Someone's asked, does this come and go, or once it occurs, is it permanent?
Oh, good question. Good question.
Come and go. It definitely can increase as the memory loss increases because maybe they accepted it and everything, and then as time goes on, it's like, well, I don't have that when you tell, they forgot. So in that way, I could say yes. Have I ever known anybody that's ever had it and then all of a sudden comes to accept it? I have not.
I don't see that either.
Yeah.
I think that's a characteristic, a symptom that tends to stay. If it's one, we have symptoms of Some people have constipation, usually doesn't go away once it's there either. There's lots of things. So, but that is a fairly static.
It's a good question.
Somebody answered it too. I didn't see them. Anosognosia is permanent in advanced levels of dementia. Is there anything different in interactions in the advanced stages?
As far as how we would approach somebody with advancing dementia. So yes, I mean, we communicate, when people are in earlier stages, I think there's a lot more in the way of trying to partner in decision-making and get people's insight. One of the reasons that we talk about diagnosis early is because people can have their wishes known, their opinions known, contribute to their own medical decision-making, but at some point they're not able to have the capacity to make those decisions. And so those become the care partner or caregiver's responsibility, or healthcare power of attorney, that kind of thing. And so, so really at that point, more of the burden of making the decisions without partnering quite as much, but we aim to reduce stress. That's what we're trying to do. So to involve someone in their care, if it's mounting stress, and now we're at the point where they're not able to participate, we really want to kind of keep the interactions to the more pleasant ones, if we can. So we don't need to burden them with the complexities of a diagnosis or why we're talking about a medicine. We really want to kind of tailor it to how can we make this relationship in the day-to-day better.
Again, it's that connecting with those feelings, and it never does any good to say, really, because I just explained that 3 times in a row. And, that just causes some more of that kind of that agitation. So it's not necessary that we go there and explain that. And you can reteach yourself again and saying, I don't know, whatever the issue could be at that point. My mother-in-law didn't think she took medicines. What are you doing? I'm organizing your medicines. I don't take medicine. Would it behoove me to stand there and say, well, yes, you do. You have this, you have this, you have this. I just filled up her medicine organizer and I said, okay. It's like, think about it. What are we going to get tangled up with? It doesn't matter. And she took her medicines just fine when it was time. So that kind of a thing about it doesn't add up. She said, I don't take medicines, but 2 hours later, she's taking her medicine. I'm not going to point that out. And that is the inconsistency too, that I think you'll see.
Just a reminder for folks on Zoom, if you want to turn your mic off and speak and ask a follow-up question, you're totally welcome to do that, or you can continue to type in the chat box. And we have one in the chat box. Is their behavior more combative versus compliant with anosognosia?
We can answer this one. The combative, unfortunately, is generally, more of a defensive. Doesn't mean physically aggressive by any means, but more of a defensive. Because of course, I give people the example, if my mom and my husband came in today and sat down with me at this table and told me things that in my mind, how I feel right now was true, it would naturally, I would say, well, call the experts. I want 3 other opinions. You're all being wrong. But ask my coworkers, I'm fine, and you would try your best to stand up for yourself and explain as you should, right? So it's a very valid emotion that feels very appropriate to somebody. And so the more we try to convince, the more that feeling comes. So the only way to kind of bring down that agitation is to pull back and agree and let people feel heard and not. And so that is really, and then sometimes it takes, months of not starting a medicine and just reducing the conflict that sometimes has been building for a year or 2 as we're trying to get someone into a memory clinic, for example. Those conversations probably were really, really difficult. But then if we can kind of acknowledge this, and this is what's going on, let's just pull back. Let's not try anything different except for the bare minimum, and then come back to it when people feel connected and we're having a better relationship for a few months, So, but yes, the harder we push, the harder the pushback generally.
Any other questions?
I have a point. If you get a chance to read this book,
Oh,
I strongly encourage you to read this book. I want to draw.
Is that the one they mentioned?
Yes. And we'll put that up on the screen.
I'm gonna put it up right
after.
now. Okay,
I
thank you.
want to draw a parallel with mental illness.
Yes,
if I can.
because that's.
Because he starts off in his book talking about his brother.
Mhm.
And he makes the point, which I think is relevant here as well, in memory issues, that mental illness left untreated gets worse. It progressively gets worse. And I think we could probably say that the same thing about memory issues. And so he makes the point of how important it is to get on this quickly. Don't drive it, just use this process, be patient, and trust. And that's, and
Trust what?
trust that the process will get you where you want to go. Will get you to,
I'm sorry.
get your loved one taking medicine that they need.
I think the approach that, you know, Dr. Amador from, you know, and all the reading we've done, I mean, the end result is someone accepting things in treatment is a very different part of this. The connection, the keeping in contact, the safe place, if there was something really serious going on, you know, if there's any connection that remains without an agenda to get to there, sometimes that's all we can
Yes.
be. Now, the one piece I wanted to emphasize, I don't think that we've brought it up enough. We touched on it. One of the biggest pieces of this is to get support for you. And this applies to your situation. This applies to the people that we see in clinic.
Hallelujah.
It's vital no matter what situation we're in when we have a loved one's health in our hands to get support, but it's ultra vital with this particular situation, with all these unique challenges we're dealing with. And that is a treatment in itself for your loved one, for you to do this. This would not be intended. So there's support groups for caregivers. You try and you find there are individual counselors who are experienced in this that can delve a little more uniquely into this, because sometimes you show up at a support group and nobody has this particular issue and it still feels alone. But one-on-one, people can help. There are the NAMI support groups, National Association of Mental Illness is excellent, and they teach these kind of techniques. They're very familiar with anosognosia. And so even people who have dementia that they're dealing with could touch onto the NAMI support groups, because that's much more commonly known in the mental illness community. But that's so vital, because none of this is easy. There's, as Chris said, there's these approaches, there's techniques, there's time, there's effort, but we still need the support, because it's really, there's no magic. And somebody asked, actually, is there medication? There is not. And that is one of the,
I'm sorry, say that about medication.
someone in the chat asked, are there medications specifically for people with anosognosia? And there's not. There is no medication treatment for this symptom. And so that's where us trying to learn our techniques is going to help it more than a medicine. Now, sometimes when there's coexisting mood disorders, anxiety, depression, sometimes there are other things, sleep, we have other ways to kind of, sometimes the resistance can be a little bit less if we treat these other things, but someone has to be able to accept it. So we have to kind of start with, but sometimes if somebody's not sleeping well, for example, sometimes there are medicines that treat two things. They treat sleep and anxiety. And so sometimes in the, provider world, we're thinking about, okay, how can we kind of, if their back hurts, there are some medicines that treat pain and anxiety or pain and depression. And so we can kind of try to, something for back pain can also help someone's anxiety. We don't have to drill that in, but that's another benefit to the medication. So we can kind of think creatively too. And there's another question.
Our person becomes concerned when she has her regular checkups. She asks, is there something wrong with me? What are you not telling me? If we respond with it's a regular checkup, she persists asking. If we respond by relating that she is physically healthy, the concern is your memory, her reaction is very negative, denial, and pointing out certain recent circumstances like the pandemic caused her to have trouble remembering. How can we best handle quarterly interactions?
What was the last sentence, please?
how to best handle these quarterly interactions.
Before.
Well, I think, I mean, but see, so she's acknowledging that the pandemic has caused some memory issues, which it did. Like isolation and lack of stimulation worsened everybody's memory. So that's exactly how kind of I would approach it, is that we're kind of working on those particular issues that the pandemic kind of led to that little bit of more memory loss. We can actually work on that with your physician. It takes time to come back from that. And that might be something, an approach, a lead-in. So that's just one piece that stands out there that might be helpful. But sometimes people, you know, even if we've explained, I mean, we have this a lot, right, where people will sometimes ask me what's wrong, and we can talk about it honestly and openly. And then right after that, we'll say, tell me, you're not telling me something's wrong. And we've tried different techniques. I mean, we've tried and failed things too, believe me. We've written it out, you know, on a prescription or on a discharge summary, or give someone education. But sometimes that will just re-traumatize people, and it's not helping the situation. You know, if they say, I'd like to see my mother again, and we say, oh, mom died, and it brings on a grief. And then in 2 minutes, I want to see my mother again. We don't want to keep saying that, right? So we try to really individualize the response and whether it's beneficial or not. Sometimes it's more distraction and trying to lessen the frequency of the questions. Sometimes there's, different things we can get people involved in that usually takes our brain off it. If we're having a lot of downtime, that tends to kind of lead to more of the repetitive questions. So that's kind of another avenue. But yeah, it's a challenge to be honest when someone wants honesty and then not retain that.
They don't really want honesty because of the way they're reacting when they do, or they are honest. I was reading their message and it's like, she doesn't really want to know. It doesn't sound like.
I know. And then can't retain, has a hard time remembering.
Yeah.
That was really something.
I have a question. So my question deals with how to handle this situation with my husband who has dementia, and when we're in a social situation with friends. And part of what goes on with him is that there'll be a word that somebody will say, and that will trigger something in him that is way off the conversation. And I understand the trigger because I know him so well. I know what he's doing with it. And it's way off, and it's going to be a very long story that's going to pull. Okay, I'm sitting there thinking, just let him do it. This is fine. And then the other part of me is saying, you need to look out for your friends and not let them hear all of this and go. And so I'm sitting there with stress, trying to decide where my loyalty lies in a way. Who do I protect?
Yeah.
Is there a way
Well,
to
that's real life, isn't it?
It is real life. I just came from that.
Right.
5 minutes ago. 55 minutes ago.
If I could interject, depending on the setting and depending on how well the friends and the social environment is, I had a little card that introduced the fact that my husband had memory issues, and sometimes the card would simply say, we're dealing with dementia, please be patient. So sometimes just being able to secretly have that in the social environment would make things easier. People would be more accepting, and a lot of them wouldn't care if the story went on for 10 minutes.
You did? Yes. But all these people know that he has that, but still.
I mean, if they're really close,
patience.
yeah, they're good. If they're really good friends, and and they know, and you've talked about kind of the situation with them, that side conversation before another outing could be, I'm aware of this, you're aware of this. If we give each other a little signal, we're going to both distract, we're going to change, sometimes, like, for example, if we're in a visit and somebody is speaking in maybe tangent kind of way and very focused and on a path, and we have to kind of regroup, and, it can come off upsetting occasionally, right? But we try to do something like, a touch on the arm and say, I love that story. I love that story. I'm going to get back to that in just 1 second. Let me just ask you something really quickly before I forget. And then maybe veer off.
And
or
then kind of
something.
redirects them.
Yeah, it can. None of these are perfect, but that's something that I might try, because if I need to get a physical exam done and get back to it, right, just as an example, to cut someone off who's talking, it even puts me on edge. I don't want to upset someone. I want to build rapport. I want to do all these things, but sometimes just acknowledging and then taking a little bit of a risk that they might be kind of upset with me, right? And as much as I'm trying to be kind and respectful, usually that will wane and it won't be a grudge. That's the other thing to remember is that the memory, short-term memory loss, there's a couple benefits. And one of them is usually a grudge is not held too long. So you'll have time to practice another time. But if your friends know that and they don't just think they're on a limb or going to upset him or upset you, you can both kind of have a little, okay, if this happens,
You both, meaning the friend in you, or
no, I mean, if it's a really close
patient in you, I'm not.
no, I would say the
the
friend. Yeah, I mean, if it was a very close friend,
Oh,
I might have this conversation saying, I understand that sometimes the speech can be a bit tangential. And if that happens, here's what I'm going to do about it. You feel free to kind of play off me a little bit and we'll just, we want him to be included in conversation.
Yeah.
But we all know that this is one of those symptoms that we can kind of get trapped on a little path. But if they know, then they won't be upset by changing the subject or you changing the subject. And
I think it's striking a balance too. I mean, if he's enjoying telling the story,
yeah, sometimes just let the story be.
that's
Right.
good for him.
Yeah.
And you know what? I would say that you sound like you have really great friends. And honestly, maybe you're not giving them enough credit to just be willing to listen to them. If they know, they're probably happy to just listen.
Yeah, but if it's the second or third time that the story's being told, that's
That's a different thing. They probably still understand that,
Yeah. And it would take the pressure off you though.
Yeah.
They said, it doesn't bother. So I'm just happy he's out here.
Yeah.
And that's great. So,
Yeah.
Okay. So I think we did.
All right. I think we've covered all the any other questions we haven't hit?
Have any of you ever asked your loved ones, they have, just like the stories we're talking about, to sit down and recall as best they can, particularly wonderful story, and record it for your grandchildren and your children.
That's a gift.
Because I was with a friend the other day, and he was telling, he's a tree expert, and he's taken over a business for a guy he used to work with, and I said, "Dang," I said, because he was talking about his friend was sharing stories of when people came down here from the mountains to bring trees to plant on Queens Road West. And I mean, that's how far they went back. And I said, dang, you got to sit down with a recorder. And his friend has dementia. And I said, get these stories. These are wonderful stories. Just make it part of their legacy.
That's a gift. It really is.
It's another way to build connection is to take a pause in trying to get things on the path we want and actually connect.
Yeah.
And show them that they, it's great. All right. Well, thank you all. I appreciate you coming.
Thank you.